to our Wednesday evening webinar. I'm getting a bit like a news broadcaster now because I'm accustomed to doing this every Wednesday evening, and it's nice to see so many new faces as well as those who have joined us on a weekly basis. This is an important topic which is very relevant to RCSI's mission and our ambition and our wish to be supportive of population health and particularly global surgery. I'm delighted that Professor Camilla Carroll, who chairs our committee on development and global surgery, is going to take the chair of this meeting. And Camilla, thank you for putting together a very interesting program. And I, like all the rest of us, I'm going to sit back and listen now to what I hope will be a memorable hour or so of discussion. So Camilla, will you take over, please?
Thank you very much, President O'Connell, and it's truly an honor to be here tonight. Good evening and welcome to RCSI.
Camilla, we need to get you maybe closer to the mic because you're a bit distant.
Good evening and welcome to RCSI Member and Fellows Wednesday webinar series. Tonight's topic is global surgery and RCSI sustainable collaborations and partnerships. Professor Camilla Carroll is my name. I am a member of the RCSI Council and an ENT surgeon here in Dublin.
Camilla, you've somehow gone mute again.
I would like to acknowledge the global attendance this evening, with surgeons joining us from Ireland, the Middle East, the Court of Examiners, Bahrain and Dubai, COSECSA members and fellows from the continent of Africa, and from the Geographical Centre of India, Professor Sharma. We are also joined by Irish surgeons in training, represented by ISTG, and RCSI students from the Surgical Society, the Association of Women in Surgery, and Incision Ireland. You are all most welcome. Last November 2019, I attended the COSECSA annual conference and conference in Kampala, Uganda. The theme of the meeting was Access to Safe Surgical Care, a Universal Perspective. 1 year later, on November the 17th, 2020, a team of 20 specialists.
Sure. I'm listening to webinars, so I'm all ears to you now.
A team of 20 specialists led by pediatric surgeon Dr. John Sekabira successfully separated conjoined twins in the new operating complex at the Malago Hospital in Kampala. The twins had access to safe surgical care carried out by experts and at no cost to their family. This was as a result of the surgical training and education being delivered regionally by COSECSA. Tonight, it gives me great pleasure to welcome our first guest speaker, the President of COSECSA, President Godfrey Ignatius Muguti. Professor Muguti is a general surgeon with specialist training in plastic and reconstructive surgery. He is the Professor of Surgery and Chair in the Department of Surgery at the University of Zimbabwe and Clinical Professor in the Department of Surgery at Stanford, USA. Professor Moguti is an honorary fellow of the Royal College of Surgeons of England, and currently he is the co-director of COSECSA, University of Oxford Orthopedic Link Project COOL. Professor Moguti, please, the floor is yours.
Godfrey, your mic is muted.
Thank you, Professor Carroll, for your kind words of introduction. I'm very pleased to participate on this platform tonight, and I would like to thank the organizers for giving me an opportunity to share with you our vision for 2021 to 2025 in COSECSA, one of the youngest surgical colleges, but clearly one of the most active in terms of training and education. Warm greetings to all the panelists and to all those attending this webinar this evening. I wish to thank the organizers for inviting me to speak on behalf of my college to share with you our strategic vision for the next 5 years. This 2021 to 25 strategic plan of the College of Surgeons of East Central and Southern Africa is a product of contributions from within COSECSA and from our many collaborating partners. Allow me to make special mention of the Chief Operating Officer of COSECSA, Ms. Stella Itungu, the Chairman of the Finance General Purpose Committee in COSECSA, Dr. Wakisa Mulwafu, and the Royal College of Surgeons in Ireland and COSECSA Program Coordinator, Ms. Deirdre Mangoang, who have been the driving force behind this strategic plan. I would also want to thank our major collaborating partner, RCSI, for making some important suggestions which have been incorporated into this strategic plan. Next slide, please. This is a quote from one recent major journal. 6.5% of the global burden of disease is amenable to surgery. To effectively meet healthcare needs, the existing surgical workforce would need to be doubled in the next 15 years. A major challenge indeed. Next slide. Next slide. COSECSA, therefore, is dedicated to scaling up surgical services and care within the East Central and Southern African region by increasing the number of appropriately trained, well-qualified surgeons and supporting the development of anesthesia, perioperative nursing, and obstetrics workforces. Next slide, please. This is a busy slide, but it summarizes the activities within COSECSA. I'll just take a couple of minutes to highlight some of the important issues on this slide. So by August this year, 2020, our trainees within the COSECSA region had reached the 250,000 mark, 250,000 operations entered into the e-logbook. And this is from the 18 countries, as you'll see later, that train under the ban of COSECSA. Looking at the age demographic, we see the majority of the patients that come for surgery are between the age of 1 year and 45 years. And this is in keeping with the relatively young population in Africa, where age is at about 20 years. The 701 trainees who have entered these operations that are depicted on this slide have registered 2,700 different types of operations. And as can be expected, the majority of these, up to 68, nearly 70%, are in orthopedics. The country's top 4 countries that have entered these procedures in the logbook are Kenya, Zambia, Ethiopia, and Zimbabwe. Looking at the actual surgical procedures, we see that complex major operations were conducted in a significant number of cases, but most of the operations tend to be major and intermediate operations, around nearly 60%. The indicators that we use to measure our performance are access to surgery, surgical workforce in terms of numbers of surgical trainees and qualified surgeons, the surgical volume that we are able to handle, and how safely we handle these surgical procedures, and affordability. Next slide, please. So this slide shows the reach of COSECSA. It's become a very big college indeed. 14 constituent member countries, but runs training in 20 countries in Africa. It has clearly become the biggest institution, offering surgical training on the continent. Next slide, please. In our 2016 to 2020 strategic plan, we had 4 major goals: graduate 500 surgeons by 2020, achieve excellence in training and research, maintain best practice in examinations and assessment, and build organizational excellence and financial sustainability. Over this 5-year period, we've registered some major successes. By the end of this year, first 2 weeks of January, we'll have breached the 500 mark, having gone beyond our estimates for the strategic plan. We now have within the region 303 fully trained and accredited surgeons who are trainers in COSECSA. The first cohort of trainers was trained by the Royal College of Surgeons of Ireland, and it also trained master trainers. Now we've got 58. And for the last few years, all the training has now been done within the region. We have more than 700 trainees cumulatively, since we started the college. All the hospitals that we train in are accredited by members of council, regulatory bodies, and local surgeons. So all training takes place in fully accredited hospitals. And we've got program directors who are in charge of the training at every site that we use. We've also started this year to administer online examinations. Next slide, please. This slide shows the trends in terms of program entry. When we started off the college around 2001, 2002, you can see, the start was rather slow, but as confidence started to build up within the region, by 2012, the number of doctors registering in the college for training started to increase. And after 2014, we can see the increase has been exponential. Obviously, COSECSA had to prove itself, competing with the university-based programs in the region, which we call Master of Medicine. And as confidence started to increase, we can see that there is a lot of confidence among young doctors aspiring to become surgeons. In the slide just at the bottom, we can see that 50% more or less of the current students in training are in the membership program. And looking at those now in the fellowship training, the last 3 years of the 5 years of training, the majority, as would be expected, are in general surgery and orthopedics. But what is also very clear, if you look closely at the figure, is that just about every specialty in surgery is now carrying out training within the COSECSA college. Next slide, please. So this slide, again, like the one with program entry, shows the exponential increase in the number of trainees graduating in COSECSA after the year 2014. Showing a lot of confidence in the way COSECSA conducts business. And in actual fact, we've now reached a stage where the combined number of all our university programs is now less than the number of surgeons training using the collegiate model in COSECSA. And looking at graduates by country, as we saw already on the logbooks, Kenya has got a large number, followed by Ethiopia, Zimbabwe, Zambia, and so forth. Next slide, please. One of the issues that we have been seized with in COSECSA is to try and encourage women to join the surgical training program. The beginning was quite difficult, but we can see, slowly in the last 3-4 years, the number of females joining surgery has really shot up. And I think this has been due to a number of initiatives within the college, just persuading students in their formative years to get an interest in surgery. And within COSECSA, there is an advocacy group for women which was formed, which is called WISA, Women in Surgery Africa. And this has become very active, and Council has tried very hard to support this group, and they've been given a seat on the Council. And I must say that the female contingent within the American College of Surgeons has come in a very strong way to support this group of young women. And the College of Surgeons, American College of Surgeons, has also made scholarships available specifically to try and incentivize female surgeons to pursue programs within our college. Next slide, please. This we have already seen, the number of graduates coming through the collegiate model. Next slide. Next slide. Now, looking at the 2021 to 2025 strategic plan, this is a continuation of the 2016-2019 2020 strategic plan, but this time we are concentrating on 3 main goals: to graduate 1,000 surgeons by 2025, achieve again excellence in training and research, build organizational excellence, and financial sustainability. Looking at goal number 1, to achieve our objectives, we feel that we have to accredit an additional 30 hospitals for training. We have to train an extra 100 trainers fully accredited within the COSECSA program. We are also going to put in place an award framework for trainers and master trainers to try and incentivize them so that they can champion the cause of COSECSA. We again try to increase the number of female trainees in the surgical programs. We hope to achieve a quota of about 20% by 2025. These we hope will be female trainees within the college. We also want to review an online accreditation system of our hospitals. We run a journal within the college, which is called the East Central African Journal of Surgery. It is the successor to what was called the Proceedings, which was like an in-house journal of the Association of Surgeons of East Africa, which some of you may know was formed in 1950 and is the predecessor of COSECSA. Looking at goal number 2, we want to strengthen our collaboration with allied health professions that are engaged in surgical care and training, strengthen our relationships with anesthetists, obstetricians, nurses, and so forth. In some of our countries that have non-surgeons, we want to try and improve the numbers going through training in those programs. Members of the college are actively involved in the national surgical anesthesia and obstetric plans to try and help the different countries create a roadmap for development of surgery, in their health systems. We also plan to review accreditation of the status of our specialties, which we do every 5 years. Looking at goal number 5, COSECSA wishes to implement an effective communication strategy within its network in the college and internationally. We aim to try and develop a piece of land that we've been fortunate to get in Arusha, which was donated by the Tanzanian government. We hope in the next 5 years we start developing this piece of land into the headquarters of the college, which will house our secretariat and do other important activities of the college. We're also working very, very, very strongly at trying to implement fundraising strategies that are effective. And we are on an active recruitment drive within the different countries to increase our membership and fellowship within the college, hoping by the year 2025 we'll have a membership within the college of more than 3,000. Next slide, please. We all know that the COVID pandemic has had a huge impact in every aspect of life, globally. And it has negatively impacted many aspects of our activities as surgeons, both in terms of delivery of surgical services and surgical training. But due to the resilient systems that COSECSA has put in place over the years, we were able to embrace these challenges and continue to function effectively as a college. Obviously, because of the impact of this pandemic, we've had to postpone some of our major activities. For example, our first meeting, which was an executive meeting, we had planned to hold it in conjunction with the Kenyan Surgical Society in Mombasa. That was the first major event that we had to cancel. We subsequently had to cancel a council meeting that was supposed to be held in Mozambique in August. And all these meetings have now been held on the virtual platform. And I must say that the college has been able to effectively discharge its duties and responsibility on the virtual platform to a point where even in future, to cut on costs of running the college, we will continue to have some of our activities online. But of course, we will need to have physical meetings, to make sure that the college continues to function effectively. And I'm also happy to report that for the first time, possibly forced by the COVID pandemic, COSECSA has now held a very successful online examination. And next month, in the first 2 weeks of January, we're also going to be running blended clinical examinations, which will combine examiners locally within the COSECSA region and some examiners online from overseas. And COSECSA has also been quite active on the international platform, with a number of members of council participating as panelists and speakers on a number of major international webinars and online conferences. Next slide, please. Next slide. Next slide. So I'm glad to have shared with you our vision in COSECSA. And I must say, we have been a very fortunate college in that globally, we have a lot of friends who are prepared to share their experiences with us. I thank you.
Professor Muguti, thank you very much for sharing the past the present, and the future of COSECSA. You have demonstrated that you have been able in a very short period of time to translate goals into tangible achievements, and congratulations. We will have many questions for you at the end of all of our speakers. Thank you very much. It gives me great pleasure now, as Professor Moguti discussed the role of COSECSA in encouraging women to train to be surgeons, and how our colleagues at the American College, Professor Hilary Sanfi and past President Barbara Bast, have reached out to WISA to assist you. Tonight, I am going to introduce Dr. Ngozi Ofaya, who is going to share her insights from her various roles as a mentor and coach of medical students in Ireland and in Vietnam. Dr. Ngozi Ofaya is the National Clinical Lead for the Intern Training Program in Ireland. She is a senior lecturer in the Department of Surgery at RCSI University and School of Medicine. Dr. Ngozi Ofaya has been involved in the delivery of health professional education for over 10 years. She holds a master's degree in medical education from QUB, an MD in surgery from RCSI, and currently she is completing her PhD studies, where she is evaluating gender diversity in medical education and training. Dr. Ngozi Ofaya, I would like you to present your information. Thank you very much.
Thank you very much. Good evening, everyone. I am honored to be asked to speak at this webinar. Special thanks to Professor Camilla Carroll for inviting me to speak on the topic of women in leadership engagement in global surgery. Next slide, please. My 15-minute talk this evening is going to be divided into 4 sections. I'm going to start off with my PhD data, presenting what I've done so far and the impact it's had on surgical recruitment and surgical retention. Then I'm going to move on and talk a little bit about leadership and mentorship. In the 3rd section, I'll talk about some initiatives that I've been involved in, as Professor Camilla Carroll has mentioned, around Vietnam initiatives. And then I'll finish up with the next steps of how to really encourage more women to pursue a career in surgery. Next slide, please. Next slide. I am currently undertaking a PhD in gender in surgical careers in the University of Dundee, and it's focusing on exploring female surgeons' identity constructions and the whole idea of intersectionality, which I'll go into in a little bit more detail. I'm also going to see how this whole identity constructions really impacts on the success and retention of surgeons within the specialty and within the career, but also the impact it's had on leadership positions. I'll be sharing some of my preliminary data of what I've got, because I haven't quite finished yet. I'm still in the write-up stages. This study was a qualitative study between Ireland and Scotland, and obviously there's a lot of collaborations with other universities as listed there. Next slide, please. Evidence and several literature has shown that gender imbalance exists worldwide in surgery, with women disproportionately underrepresented at higher leadership levels. The workforce challenges in the NHS and the HSE now present a greater threat to health services than funding challenges. International data also reveals that underrepresentation of females in surgical leadership positions and academic medicine is a universal issue. Professor Muguti talked about the AAMC, and in 2000 they created a Women Leadership Project Implementation Committee, and this was to help with gender diversity in the workplace. In 2016, a study that was carried out in the States showed that despite the improvements and the initiatives that have been put in place to increase the number of women in surgery and in leadership positions, that there was still a significant gender gap between male and female surgeons in leadership positions. And this is comparable to the UK, it's comparable to Ireland, it's comparable to international experience. Next slide, please. The lack of female leadership poses a shortage of role models for young aspiring surgeons. And of course, the lack of role models reinforces negative perceptions of surgery as a problematic career. Vertical and horizontal segregation has led to underrepresentation of women in leadership positions. So when we talk about horizontal and vertical segregations, horizontal meaning a concentration of people in different kinds of jobs, but also vertical segregation is the one that we're all aware of, the colloquial language of glass ceiling effect. And that's where you have under or overrepresentation of a group of people at the higher level of the organization. So my study aimed to identify the main challenges for female surgeons, but more importantly, and I suppose the novel aspect of it, was really to look at the perceptions of their colleagues and their patients as well. Next slide, please. The methodology used for my study was a qualitative study. Obviously, the epistemology around it was social constructionism. The theoretical approach that was used was one of interpretive approach. There were 60 participants individually interviewed for this study across Ireland and Scotland. And then for the analysis, I used thematic framework analysis to code the themes that were coming out of the data using the software NVivo. Next slide, please. The main novel finding from my PhD is intersectionality. So what do I mean by that? Intersectionality was first introduced in 1991 by Kimberly Crenshaw, and she used the term to talk about intersections of different identities of individuals. So personal identities like gender, race, ethnicity, social class, religion, they all intersect with professional identities. Next slide, please. These professional identities and these merging of identities has obviously been seen in several places. The theory suggests that no one identity is prioritized over another. It emphasizes that gender may or may not be a priority for women when they construct their multiple identities. Next slide, please. Identities of professional identities of being a surgeon, being a doctor, being a leader, a role model, or mentor were identified by the participants in my study. But additionally, their personal identities were of gender, ethnicity, age, or parenthood. Next slide. So novel findings from my study show that female surgeons construct intersecting identities around their gender and motherhood or around their gender and ethnicity. In addition, colleagues of female surgeons and patients of female surgeons were able to also construct this intersecting identity of female surgeons with a common intersectionality of being a female or being a mother. Ultimately, the findings of my PhD show that it is possible to achieve a balance between professional and personal identities. And thus the argument that being a mother is a barrier to choosing a career in surgery is completely out the window, and one that we need to make sure we break that challenges that people see, that perception that people see when they want to choose a career in surgery. And such gender should not deter women from being at leadership positions in surgery. Next slide, please. The next part of my talk focuses on leadership and mentoring. We talked about the lack of representation of women in leadership roles, and this is impacting on role modeling, is impacting on recruitment, is impacting on mentoring of potential future surgeons. Next slide. Next one. Next slide. Thank you. A study by Elspeth Hill in 2013 showed that female surgeons were unable to identify with other women in surgery. They found challenges to actually see themselves as female surgeons.
To the hospital. They stayed in the hospital for a very long time on IV antibiotics, despite the fact that those wouldn't have reversed the necrosis. They spent many months in the hospital until their money ran out. So we see in Blessed's story the fact that surgical disease and the impact of barriers to surgical care is more than just the impact on Blessed's health. Obviously it's there, right? Her lips are gone. And the establishment of referral systems and evaluation of national surgical plans through the Surge Africa Project, the Cost Africa Project, the Kids Surge Project. So building on that foundation, where is the best way for RCSI to move in the next 3 to 5 years? And to answer that question, I want to come to this adage that I really like, which is that all monkeys cannot hang on the same branch. So let's take a look at all of the branches here in the story of Blessed Surgery. And let's talk about the branches that a lot of people are hanging on. For example, you have a lot of work already being done in the development of national surgical plans. You have a lot of work already being done, including with COSECSA and RCSI, around the training of providers. Work being done, for example, by Lifebox around improving the infrastructure of the surgical systems. So if we pull out from this formalization of the deeper underlying systematic disease, the branches that people aren't necessarily hanging on, what we find are areas that RCSI has developed a fair amount of experience in already. Things on the left-hand side of the slide, things that directly affect the patient herself, things like the patient-side barriers, as well as some of those second-level outcomes of surgery, those non-health outcomes of surgery. So with that in mind, the vision for the next 3 to 5 years of RCSI in global surgery is to build on this decade of experience in surgical training, education, and research partnerships. And the Institute will build on those to deliver the following vision. The vision is this, that rooted in equity and in collaboration with our partners, we aim to create patient-centered, outcomes-based global surgery research and education programs. So 4 pillars in this vision. The first pillar is a pillar that I'm glad we've been talking a lot about today, which is a pillar of equity. There's a reason that we've listed it first, because global surgery, both in the delivery of care, in the training of clinicians, as Dr. Ophia has spoken about, and in the research world, there is a significant amount of inequity, whether that's inequity in socioeconomic status, inequity in race or religion, inequity in gender. Again, to get back to Dr. Ophia's presentation, an intersectionality of the inequities in global surgery. And our goal is to start to root out those and to start to move a little bit more towards equity. A pillar of collaboration locally within RCSI, within the Republic and the island of Ireland, and then more internationally with our collaboration, for example, with COSECSA and CANEXA and Kids OR. With those collaborations, we really want to focus in on what's happening on that left-hand side of that graph, what's happening to the patient, what are the barriers that she had to face, and what are the outcomes that she might care about after her surgery is done. And to create everything that we do, to base everything that we do in evidence. And if that evidence isn't there, then we commit to creating the evidence for the programs that we put forward. Because the thing is, in global surgery, we're getting a lot better. There's a long way to go, but we're getting a lot better at what happens within the walls of the hospital. We're getting a lot better at the staff, the stuff, the space, and the systems that are required to deliver surgery for Blessed. We're getting a lot better at moving Blessed from here to here. However, if we want to start to chip away at the unequal burden of surgical disease, it's worth it for us to take a little bit of a step back from the what and the how, and to start listening to and responding to the why. Thank you very much.
Thank you very much, Professor Schreim, for sharing that information with us. And I think that it clearly summarizes the importance of understanding the surgical ecosystem if we are indeed going to make a difference in trying to increase the workforce and increase the access where patients and their families are able to afford it. Given the fact that we are extremely over time, and I would like to say sorry to everybody, but thank you for staying tuned in. Dr. Bharti Kulani is now going to present, just for a brief moment, a new departure in RCSI and the other medical students in Ireland in regards to engagement in global surgery. Thank you very much, Dr. Kulani.
Thanks, Prof. Camilla. Good evening, everyone, and thank you very much for this opportunity to speak at this wonderful platform to introduce Incision Ireland. My name is Bharti Kulani. I completed my undergraduate degree in medicine from RCSI, graduated earlier this year, and I'm currently doing my internship in the Cork University Hospital. This year, myself and my colleague, next slide. This year, myself and my colleague Katrina Nagasima have had the privilege to establish Incision's first Irish chapter, also known as the Irish National Working Group for Incision. Katrina has completed her bachelor's in biology from the States and also a master's in neuroscience from Edinburgh. She is currently studying medicine from Trinity College Dublin. Next slide, please. So our head faculty supervisor this year is someone who needs absolutely no introduction. We are very privileged and lucky to have Professor Camilla Carroll as our head faculty supervisor. I've been very fortunate to have worked with Professor Camilla throughout my undergrad degree, and we are very delighted to have her continued support as our mentor this year. Next slide, please. Present also in this webinar are some of our executive committee members who are highly passionate about global surgery and were shortlisted after a very competitive application process. Our committee includes students from different medical schools in Ireland, as well as junior doctors as deanery reps. Next slide, please. So Incision, as many of you must have heard about, is an international global surgical network that initially became formally recognized as an organization in March 2016. Incision represents more than 5,000 members in more than 80 countries with 45 fully established national working groups. Our vision for Incision Ireland is to establish Ireland on the map of global surgery and advocate on behalf of our patients for access to safe, affordable, and timely provision of surgical care. Next slide, please. Our mission this year is to unify all medical schools in Ireland with one common aim: the education and advocacy of global surgery at an undergraduate and trainee level. To reach out compassionately to the community, be innovative and responsive while promoting global surgery, and to empower students and medical students and doctors. Next slide, please. So our priority areas this year include not only the 3 pillars set by Incision Global, which are research, advocacy, and education, but this year we would also like to focus on COVID-19 and its impacts on global surgery, ethics, gender equality, as well as MDT care in surgical patients. Next slide, please. So in conclusion, we are positive that the establishment of Incision in Ireland will meaningfully impact medical students and healthcare professionals and will help magnify Ireland's contribution towards global surgical needs in the long term. Next slide, please. So myself and Katrina are truly delighted to be representing Incision at a national level and helping set this noble mission in Ireland. We are very eager to collaborate with other organizations, of which many of you represent. We are truly excited about the possibility and the future of global surgery in Ireland. We hope that we can count your support in as we move forward in this. Thank you very much.
Thank you very much, Barty. President O'Connell and myself have discussed offline the fact that we have had such amazing contributions from all of our guest speakers tonight. We're going to have to return another evening for another webinar when we will have some questions. So I think I'm going to hand over to Professor O'Connell for a few words in conclusion. I thank all of our guest speakers. Maybe they might turn on their videos, and I apologize that currently we have no time for any audience questions. Professor O'Connell, please, President.
Thank you, Camilla, and particular thanks to our five presenters. I mean, what a real range of topics we've covered. And Godfrey, what you've achieved with COSECSA is amazing. And we in RCSI are delighted to be part of the journey and supportive of it. Gozi, I really enjoyed your presentation. I never thought anybody could get a PhD engagement, and it's very interesting what you found, that the identity that women don't see themselves as women particularly, they see themselves as surgeons, but it's the need for role models, I think. But increasingly they're there, and in our college and in the American College of Surgeons, and yourself and Camilla and other, we have several council members who are really successful female surgeons. So I believe that those role models are there, and there are going to be more of them. So that's wonderful. Martin, your work is legendary, and I think the success of what you have done is truly astounding, and your ambition to go to Ulaanbaatar in Mongolia, and we will have a surgeon from Mongolia speaking at Charter Week, so that, and a lady surgeon at that. So we're covering all our bases, I think, Martin, and we wish you well in it. Mark, as always, spectacular presentation, and your ability to link the meaning of the presentation to a real life situation, and this awful facial disfigurement. I trained at Mayo Clinic, and I remember there was a famous plastic surgeon there who adopted one of these poor children and reconstructed the face. It was really an astonishing achievement. So we're in awe of what you do and highly supportive of your ambition. And Barty, I am so pleased to see the next generation coming up and having the goal and ambitions that you have. So well done, and thank you for participation. And we had at one stage over 150 people from around the world joining us. So good night to you all. Thank you to our presenters, and we hope to see as many of you as possible on next Wednesday evening's webinar. Thank you all.
Thank you very much, President. Good evening.
Thank you, Professor O'Connell.
Thank you.